Thank you, sir. Today we have a topic to discuss, which is very important, particularly for hospitals who are started or are already doing ECMO for a long time, or there are many hospitals which have started doing ECMO after the COVID pandemic. And today we are going to talk about the nursing care and what nurses, how nurses are helpful while managing ECMO patients. So give me 1 minute so that I can share my content, and then I'm going to start. I hope all of you can see the slide.
Yes, sir, it's clear.
Topic is ECMO, an outline. I'm going to go through a very brief outline about what is ECMO, and then I'll go to the topic on how nursing care is involved in ECMO patients. So extracorporeal life support, also called ECLS or ECMO, is a support of heart or lung function with mechanical devices, which has got some characteristics. Number one, it is usually temporary, days to weeks or sometimes months, but it is not permanent. It can be a partial support or a total support. It avoids ongoing iatrogenic injury and gives time for organ recovery and sustains life while bridging to organ recovery or replacement. This is how it started long back in 1954, and this is how the machine used to look like at that time. And this was the first successful ECLS patient in California in 1971. And you can see the huge machine, that the coils of the oxygenator, the pumps, the circuit, everything looks much more scary than how it looks today. This is the first neonatal ECMO survivor in 1975. And the name of this young girl was Esperanza. In 1989, the first extracorporeal life support organization was created in Michigan, and this is the picture from that time. And after 2002, we saw that there was mostly, I should say after 2006 rather, we saw that there has been an increased interest in ECMO and the number of ECMOs being done, and the survival rate has also increased recently because of the experience that we have gained in doing ECMO and the knowledge that we have gained in decreasing the number of complications. A landmark study which re-established the role of ECMO in adult respiratory care was the CESAR trial from ECMO in UK. And this was published in 2006 with 180 RDS patients, which showed that the survival among patients who underwent ECMO was 63%, whereas the conventional had a 47% survival. And again, in Lancet 2009, there was publications to show that ECMO survival was better than conventional. There's publications from H1N1 registry, ELSA registry, which showed that there was 64% survival among ECMO patients on VV ECMO. And also from Australia, New Zealand in 2009, there were more than 75% survival to discharge after ECMO. Recently, there has been many new studies which have come up. I have not incorporated them. Coming to the basic structure of the veno-venous ECMO, which is most commonly done in most of the centers, because of respiratory failure, It utilizes two cannulas. And as you can see, sorry. It utilizes two cannulas. One is called the drainage cannula, which is blue in color, through which the venous blood comes out. In this patient, it has been placed through the femoral line, but the tip of the cannula rests inside the inferior vena cava, close to the heart. And then this blood goes through a pump, which helps in bringing out the blood from circulation and pushing it back into the body through another red cannula, which in this patient is positioned in the internal jugular vein. And the cannula tip is almost at the junction of the superior vena cava and right atrium. While the blood is being pumped out of the body and pushed back, it goes through a membrane oxygenator, which is connected to a blender supplying air and oxygen. And with the help of this oxygenator, the blood is being oxygenated, as well as the carbon dioxide from the blood is removed. This is the basic principle on which a veno-venous ECMO works. There is another ECMO, which is called the veno-arterial ECMO, which is mostly used for cardiogenic shock. And in that case, the blood is taken out from the vein, but is pushed back into the femoral artery. If it is a femoral VA ECMO. The principle again remains the same, that it goes through the oxygenator and the pump. Now, indications and contraindications for ECMO in severe cases of ARDS. These were the reasons for which severe ARDS patients, which we are seeing now very commonly after COVID, they were placed on ECMO. These are the criteria used for the CSER trial. The criteria can be a little different in various trials, but these are more or less well-established indications. One is severe hypoxemia with a PF ratio of less than 80, despite the application of high PEEP for at least 6 hours in patients with potentially reversible respiratory failure, or despite proning the patient. Uncompensated hypercapnia, that is a PCO2 of at least more than 60, along with inability to maintain pH more than 7.15, despite the best accepted standard of care management with the ventilator. Here I must say, in order to maintain carbon dioxide and pH, we should always keep in mind that the principles of protective ventilation should not be overruled. That means we should not have a Plato pressure which is more than 30. We should not have a driving pressure more than 15. And if within these limits, or we should not have a respiratory rate more than 35. And if within this limit we cannot maintain our carbon dioxide levels with an acceptable pH, then that will be an indication for ECMO. Relative contraindications are a high end inspiratory pressure, more than 30 centimeters of water, Plato pressure for more than 7 days, FiO2 requirement of more than 0.8 for more than 7 days, difficult or limited vascular access, or any condition or organ dysfunction that would limit the likelihood of overall benefit. For example, irreversible brain injury or untreatable metastatic cancer. An absolute contraindication will be any condition that precludes the use of anticoagulation therapy. Nowadays, we have a single cannula also, which is called the Avalon cannula. As you can see in the cartoon, there are two pictures, A and B. A is a VV ECMO with a femoral drainage cannula and another arterial cannula in the interjugular vein. And in the B cartoon, there is a single cannula which is in the interjugular vein. But this cannula has to be manipulated with the help of a transesophageal echo so that the cannula enters through the superior vena cava but rests inside the inferior vena cava. There are holes in the cannula tip along with through which the blood is sucked out of the body, and there is another opening which must be placed in a way that the blood enters the body and crosses the valve, which is the tricuspid valve in this case, and enters into the right ventricle. As you can see in the cartoon B, the way the cannula has been positioned so that the hole is directed towards the valve. A chest X-ray confirmation of the cannula position is very important, and it is also important to do frequent X-rays in patients who are on ECMO to make sure of a few things. Number one is the position of various tubes, lines, cannula, and this first X-ray after cannulation will show you the distance between the arterial cannula through the interjugular and the draining cannula through the femoral vein. And the gap between these two is very important. If it is less than 10 centimeters, then there is a higher chance of recirculation of blood, and which will lead to unnecessary hypoxemia. As you can see, the drainage cannula is larger in size, 22 to 28 French, than the arterial cannula, which is 17 to 21 French inflow. We already talked about the Avalon cannula, so I'll not spend more time on this. This is how the X-ray looks with an Avalon cannula. And as you can see, patients on ECMO can remain fully conscious. They can be extubated, particularly on VA ECMO, and they can be even eating orally. Because there has been significant technical improvements in ECMO, particularly circuits are now easy to prime. The cannula can be implanted through Seldinger method. All of them can be done percutaneously. The cannulas as well as circuits have been heparin coated, so it needs much less anticoagulation, and the material is much easy. The pump is easy to use, so there's less hemolysis in the pump, and there is less requirement of blood products. Now, coming to our topic for today, after this brief introduction, is what is the nurse's role in ECMO, and how nurses play a very, very significant role in treating and taking care of ECMO patients and in the recovery and final outcome of ECMO patients. So first is, every day when a nursing team takes handover of an ECMO patient, it is important to note the day of ECMO. And while taking handover itself, you can check the cannula sites. The cannula sites are very, very important because You need to assess for erythema, purulence or pus, adequacy of the securements, and dressing integrity. Sometimes there's bleeding or ooze which is seen around the cannula sites. And this may be the first manifestation of bleeding episodes of bleeding complications on ECMO. There are various reasons for which bleeding happens on ECMO patients. The commonest being platelet dysfunction, but there can be many other causes. And it should be brought to the notice of the perfusionist and the physician to check the coagulation status, to check the heparin being given, what is the ACT or what is the APTT, and also the platelet count, and then adjust things accordingly. Also, if you think that there is infective changes around cannula or even the central venous lines, arterial lines, that needs to be taken care of. Second important is to look at the extremities. Now, extremities, what are the things to look? First is, if the patient is on a VA ECMO and there is a large cannula placed in the femoral artery, usually there's a drainage cannula placed which provides drainage to site beyond the cannula so that there is much less ischemia to the distal limb. But in spite of that, sometimes you can find mottled limb, you can find poor pulsation, you can have digital ischemia. This should be monitored very regularly, and this should be noted and notified. Even on patients who are not on VA ECMO, patients may be requiring active agents, patients may have showering of thrombus from a particular site leading to multiple dislodgement of the clot and digital ischemia. Again, this needs to be brought into notice as soon as possible and needs to be treated. There can be delayed bleeding from inadvertent puncture. For example, a femoral venous cannula has been placed, ECMO cannula. But while placing, there was a puncture of the femoral artery and maybe dilated once and then realized that, no, this is an artery. Now, immediately, there may not be any hematoma or bleeding seen. But once the patient starts receiving heparin infusion, the patient may show an increasing thigh hematoma. Sometimes the nurse can note ecchymosis in the flanks, which hints to the fact that there is a chance of retroperitoneal bleed happening. In that cases, the patient immediate attention should be given so that the patient does not go into hemorrhagic shock. Patient gets resuscitated with blood and blood products and with whatever possible to try and control the bleed. If the patient is on veno-arterial ECMO, as I mentioned for cardiogenic shock, sometimes a phenomenon happens called the Harlequin syndrome, which is basically bluish discoloration of the upper part of the body. And this is also something which can be first noticed by the bedside nurse and brought to the notice of the physician. This is an indication that the heart has started pumping better and is competing with the ECMO pump. Now, all cannulas, as you know, needs scrubbing while the dressing is being changed. If the patient, most of the time, has a little bit of ooze after the cannula is placed. So, occlusive dressings are usually not done on the first day. There is non-occlusive dressing with gauze, and these non-occlusive dressings needs to be changed every second day, or if they get soiled because of blood or things like that. If the dressings are not soiled, occlusive dressings can be left like that even up to 7 days. Please do not use betadine or local antibiotic cannula sites. Betadine containing alcohol can cause damage to the cannula walls or the material of the cannula. Chlorhexidine-based scrubbing of the patient and the cannula is recommended. The whole patient should actually be scrubbed every day with 2% chlorhexidine to prevent bloodstream infections. Skin care becomes very, very important, particularly for patients on ECMO. It's important for every critically ill patient. But ECMO patients being having large cannulas in place, there is always an inhibition of changing position for these patients with the fear that the cannulas can get displaced. So these patients are at high risk of hospital-acquired pressure ulcers. And usually a multidisciplinary team is required to assist in position change. When I say multidisciplinary team, I mean the nursing team, more than one nurse while changing position. Any other healthcare assistant and the perfusionist who is going to make sure that the cannulas are well secured, they're not getting displaced, dislodged, and it is better to be done under the supervision of the physician who is on duty at the time. There are various kinds of beds, like the combilizer beds, which have been introduced to the market for early mobilization of these very sick patients. These beds help in head elevations along with the tube, cannula, and the whole bed can become not only help you to sit, but it can even help you to stand. We all know that early mobilization of patients significantly improves outcome. Particularly, it improves the outcome of critical illness, neuromyopathy, or what we call ICU-acquired weakness. And it helps wean from ECMO earlier, it reduces delirium, and it reduces pressure source. It is also important to take care of the nutritional status of these patients, because since they are on an extracorporeal life support, and sometimes even 2 extracorporeal life supports, like an ECMO along with a dialysis machine or a CRRT machine, their nutritional requirements are pretty high. And sometimes because of abdominal distension, we may be neglecting the nutritional requirement of these patients. And that may again lead to hospital-acquired pressure ulcers. Also, if the patients are receiving very high dose of vasopressors, that can lead to poor perfusion of the peripheries, poor perfusion of the dependent areas which are under pressure, increasing the risk of pressure ulcers. Silicone gel adhesives has been advocated to be used on particular pressure areas like the sacrum, elbow, or heels. Now, this is an algorithm which has been proposed for all ICU patients by the Society of Critical Care Medicine, which is the ABCDEF Bundle. And these are kind of simple things to do but which has got very, very important consequences and outcome benefits. So A is basically to assess, prevent, and manage pain. ECMO patients usually have a higher requirement of pain medications, particularly if you're using fentanyl, because it gets used up in the circuit to some extent. Some people prefer to use morphine because morphine is firstly cheaper, and secondly, it gets much less, you need much lesser dosage of morphine to give pain relief. So pain relief is very important so that the patient remain comfortable while on ECMO. As you can understand, there are too many lines and tubes which are in this patient, and definitely that's a lot of discomfort. B is both spontaneous awakening and breathing trials. Now, after the first few days of stabilization, it's very important to wean them off or stop the neuromuscular blockers and the sedatives, and see whether they're awake, whether they're breathing spontaneously, and what is their breathing pattern. Is it kind of jerky? Is it smooth? Are they tolerating spontaneous breathing? Sometimes they do, sometimes they don't. But it's very important to check the neurological status, and that significantly reduces their incidence of delirium, as well as it helps the lungs to improve earlier. C is choice of analgesia and sedation, which I already mentioned, that it's best to have analgesia-based or analgo sedation for ECMO patients. And the sedation we usually should not be kind of a continuous benzo infusion, sometimes for a short duration of time. If necessary, we give various kinds of sedation with propofol, sometimes with dexmedetomidine, but all of these should be short duration. It should not be for the whole length of the period while the patient is on ECMO, because whether you're giving benzos or whether you're giving propofol, all of them cause a significant delirium. But sometimes you need to tide over certain situations. For example, the patient is hypoxic, even if you're on 100% of ECMO, because the patient has got a very high cardiac output, which we're not being able to match with the ECMO flows. In those situations, to calm down the patient, bring down the cardiac output, you can use sedatives like propofol. That is okay. But that should not be, that should not continue forever. D is delirium assessment and prevention and management, which is again almost the same thing. To find out whether the patient is delirious, you need to make the patient awake. Try to communicate with the patient, and the best way to manage delirium is to keep the patients off benzos and off propofol as far as possible. Give them more of pain relief than sedation. And also, if the family can visit, that's a problem sometimes in our COVID patients, but in all of the situations, if the family can visit, try to reassure them, be beside them, that definitely helps. Early mobilization, we already mentioned about special beds like the combilizers, etc. And also communication with the family, involvement with the family, engaging the family, and bringing the family to the patient so that they can get strength and support, and the family also understand the complexity of the whole thing that's going on. So that's the ABCDEF bundle, and the nurses play a very major role in all these things. Also, it is imperative to report or identify and be the whistleblower of finding out important complications that are seen while they are on ECMO. And that's why we need at least one nurse in every shift who is kind of well-trained and has got an understanding situations, because we often see complications in these ECMO patients. For example, an acute kidney injury. An acute kidney injury is first manifested as a drop in the urine output. Obviously, the creatinine, etc., which gets monitored daily in such patients. But a drop in urine output is something which needs to be picked up early. Sometimes you find that the color of the urine in the urobag is turning pink or is turning red, and that can be because of hemolysis. A light pink color of the urine is because of hemolysis. And you can do a free hemoglobin fraction of blood, but that is not very commonly done or very easily available in many centers. But hemolysis is something which can be picked up just by looking at the urobag sometimes. I already mentioned while talking about the cannula site inspections that bleeding manifestations often are seen at the cannula sites. Not only the ECMO cannulas, but other cannulas like central lines. Like sometimes they can be bleeding in the nose, they can be bleeding from the mouth, but early bleeding should be picked up so that you find out what is going wrong, and it should be stopped as soon as possible before there is a drop in hemoglobin, which is something which is a problem in various ways, because if there's uncontrolled bleeding going on, use of multiple blood products has got major problems in all patients, but particularly in ECMO patients, it can itself make the lung conditions worse because of trally or TACO. Secondly, it can cause more coagulopathy if you're requiring a lot of crystalloids to manage your ECMO flows because of hemorrhage and because of bleeding. So all that put together makes bleeding a very important complication, and it has to be picked up pretty early. For obvious reasons, one of the major causes for which there is increased mortality among patients on ECMO, particularly in India, is infection and multi-drug resistant infections. And at every cost, we need to prevent that. So very strict infection control measures are very, very important. And if you think that the patient is showing signs of infection somewhere, for example, if you think that the endotracheal tube secretions are purulent, if you think that there's a pus point around the central line, or the cannula dressing doesn't look very clean, all these things are very important to be picked up and reported. We also talked about ischemic changes, which are more common in VA ECMO patients, but does happen in VV ECMO patients as well. For example, if you have an arterial line and there is a digital ischemia in the fingers, which you're noting, you need to pick it up very early and change the arterial line as soon as possible, or remove the arterial line at least. Now, sometimes in VV ECMO patients, these patients can suffer from huge amounts of volume overload, including bilateral large effusions, ascites, tense abdominal, and sometimes combined with no or poor bowel movements. There can be extreme abdominal distension, abdominal hypertension, and sometimes even abdominal compartment syndrome. So it's very important to keep a track of bowel movements, abdominal distension, increase in abdominal girth, and if it is possible, and it's actually a very simple technique, just needs a little bit of training to find out and figure out how to measure intra-abdominal pressure. So if you think that abdomen is a problem, try to measure intra-abdominal pressure, and that can help us to identify abdominal compartments early. VAP is one of the major causes of mortality among patients on ECMO in our country, because most of the patients get on ECMO because of a viral pneumonia, for example, whether it's COVID, whether it's H1N1, but does develop secondary bacterial, secondary fungal infections. And there is a huge scope to prevent VAP in these patients. Because these patients are on very, very low tidal volume ventilations, there is much, they do require frequent bronchoscopies to look for mucus plugs here and there at ectasis. And it's very important that these bronchoscopes should be cleaned according to protocol so that VAP is prevented while doing bronchoscopies itself. We all know about the VAP bundles. I don't need to, talk again about it. The principles of VAP prevention remains the same. Just that because these patients, most of the time, we do not fiddle with the ventilator settings. So when a patient is just on a ventilator in our ICU, the first thing that we notice is the ventilator requirement goes up. For example, the patient was on pressure support, has now gone to control mode, or the oxygen requirement was 50%, now has become 60%. So something is going wrong, and we pick up infections early. But here, we rarely fiddle with the ventilator parameters. So it becomes sometimes difficult to figure out that some infective process is happening in the lungs. Because most of the times we are playing with the ECMO numbers, whether it's the ECMO flow or the ECMO sweep, and we usually not try to disturb the ventilator setting. So picking up ventilator-associated pneumonia is something which becomes a very, very important responsibility for the nurse who is actually doing the airway toileting, the tracheal toileting, taking care of the airway. And if you see purulence, if you see any change, any blood in the tracheal tube, which is coming every day or quite frequently, these are things which should be brought into notice and should be looked at. Sometimes we need to do even CT scans while the patient is on ECMO to look at certain things which you really cannot make out sometimes on chest X-rays. For example, we have seen patients on ECMO in our hospital who developed lung abscess, multiple cavitary lesions, and these all got picked up on a CT scan, but was difficult on X-rays. So prevention of VAP and early identification of VAP becomes very important, and a major role remains for the bedside nurse. Now, this is something which I want to harp very much about, the neurological assessment of ECMO patients. This is obviously a very important role for the physician, but also the nurse who is actually doing a daily assessment of the patient and can pick up subtle neurological changes from the previous morning or from the previous night. And particularly monitoring of the pupillary size, because 10% patients on ECMO develop either seizures or stroke or intracranial hemorrhage. The reason being obvious that the patient is on anticoagulants, so hemorrhage can happen even in the brain, and seizures do happen because of various reasons, maybe drugs, maybe because of small which are getting thrown here and there, particularly more common with VA ECMO. So neurological assessment of the patients along with measurement of the pupillary size and bringing to notice about a sudden change of the neurological status is very important. That needs to be urgently investigated and then communicated to the family about this new development. Like in all ICU patients, nurses form a very, very important part of the multidisciplinary team rounds. And now, because I just mentioned that sometimes, even after prolonged ECMO, the patient's lungs don't improve. The patient may suffer from irreversible brain damage from an intracranial bleed or a stroke. So there can be, or it is just not possible for various other logistic reasons to continue on ECMO. They become a very important part of the multidisciplinary team to talk about the ethics of continuing ECMO versus stopping it, the ethics of the quality of life versus the quantity of life, and the decision taken about ECMO withdrawals along with the family and the physician and the consultants. So here also there comes a very important role for the nurses. Now, what to do about cardiac arrests? This is something that all nurses in ICU patients every day. We have cardiac arrests among patients who are in the ICU, either on ventilator or not on ventilator. But what to do if the patient is on ECMO and faces a cardiac arrest? Sometimes we just freeze. Not only nurses, physicians also freeze because we don't understand the physiology. We don't know what's happening and what to do. Now, let us talk about the VV ECMO first, because that is more common and that is more of a problem, because VV ECMO supports the lungs, does not support the heart. So if you have a cardiac arrest on VV ECMO, you need to treat just like any other cardiac arrest according to the ACLS protocol. You start chest compression, you do you give adrenaline. If there is shockable rhythm, you give shock. And if possible, you come down on the ECMO flows to minimum, like maybe just to 1 liter, and continue the ECMO to run. And you need to understand that, are there any reversible cause of cardiac arrest? The reversible cause of cardiac arrest in an ECMO patient are a massive tension pneumothorax. It can be some arrhythmia. It can be an oxygen failure, but oxygen failure usually gives a very loud alarm, which is difficult to miss. And pump failure, that means the pump has stopped. If the pump has stopped, then there is something called a hand crank, which can be used immediately. And all nurses, physicians, and perfusionists working in the ECMO unit should know how to use the hand crank. You can quickly take a bedside echo probe to look at the fact that whether there's a tamponade. This is not very common, but can happen. An ABG to look for severe acidosis, either because of CO2 retention or because of metabolic acidosis. And also it is important to look at the pump head for any air bubbles, which happens because of air embolism. If air is getting sucked into the circuit because of either a breach or there is some which has become inadvertently open, air gets sucked in, and you can see air bubbles in the pump head. And that's where you suspect air embolism, which can be fatal. Sometimes you can also see clot in the pump head, which can also cause suddenly the pump to stop and lead to cardiac arrest. If there is air in the pump head, you really need to clamp both sides of the circuit so that more air does not go inside, and continue CPR, ask the perfusers to take out the air as soon as possible. Sometimes you can have air embolism even after tracheostomy, because when you, especially if you do a surgical tracheostomy instead of a percutaneous tracheostomy, because in a surgical tracheostomy, when you open up the venous sign, when you do a dissection, the veins can open up and suck in air, and that can lead to also air embolism. So important to be careful while doing tracheostomy. The rest is same as ACLS protocol. If the patient is on VA ECMO, then a cardiac arrest is slightly less dangerous unless the pump is failing. So, because if the pump continues to work, there will be some amount of cardiac output that will be maintained. The rest of the ACLS protocol needs to be the same. You may not need a cardiac compression, but the most common cause of cardiac arrest in case of VA ECMO are embolism, or it can be because of arrhythmias. So most of the time they're shockable rhythms or severe acidosis or severe hemodynamic instability. For example, the patient is in septic shock. So all these can lead to cardiac arrest, and these specifically can be addressed separately depending upon the cause of the cardiac arrest. But for VV ECMO, please continue the same care that you will do for any other cardiac arrest in the non-ECMO patients. There are certain aspects of ECMO care which are shared by the nurse along with the perfusionist. These are taking note of the ACT, bedside ACT. Nowadays, we don't send APTTs very regularly because bedside ACTs are more common to monitor anticoagulation, and adjust the heparin infusion according to the ACT. Doing regular EEGs while patient on ECMO. To note early chattering of the circuits. Chattering is a signal that there is difficulty in pulling out blood by the drainage cannula. It can be because of various reasons, the commonest being hypovolemia, so whether it's low on volume, or there is some clot, or there is some compression from outside, for example, increase in intra-abdominal pressure, intrathoracic pressure, etc. But whatever it may be, identifying early chattering and notifying the physician or the consultant is very important. Hypothermia is usually not a problem because there are machines to maintain the temperature. However, while transporting the patient, these patients can become hypothermic. So because you are not taking the thermostat along with you. So transport should be quick, very organized, for short duration, and you need to take care of severe hypothermia if the patient is outside the unit for a slightly longer time, because these ECMO cannulas are big, and as you all know that patients who are receiving, say, CRRT 24 hours for renal develop hypothermia, but hypothermia is a lot more of a problem in patients on ECMO. We don't face it because of the cool machines that we have to maintain the temperature. However, when the patient is being transported, the risk of hypothermia remains high. I already mentioned about pump clots and bubbles inside the pump, which needs to be seen. Dislocation of cannula is the worst nightmare of the ECMO unit staff. If the cannulas get dislocated, that's kind of a fatal end most of the time, because whatever may be the ECMO flow, for example, 3 liters, 4 liters, 5 liters, that much of blood falls on the floor within a minute. So if the cannulas are dislocated, the circuit ruptures, cannulas rupture, that's kind of a catastrophe that you can ever imagine. However, sometimes if it is slightly dislocated or slightly oozing, to pick it up early, fix it, is probably the best thing that can be done in this situation. This is just a picture to show you, for those who are not very familiar with the circuit and with the machine. This is the pump head. This is the point where you can see the air bubbles just below the pump head, because it's the most anti-gravity portion of the pump where the air bubbles will go and rise. This is the drainage circuit which comes inside the pump, and this is the circuit which goes out of the pump and then enters the oxygenator. This is the oxygenator. This is the oxygen port which is connected to the blender. The blender is behind, as you can see here. In this blender, you can select how much oxygen you want to give and how much sweep you want to maintain. The higher the sweep, the higher the removal of carbon dioxide. So if your carbon dioxide is high, you need to go up on the sweep. And after the oxygenator, there is another circuit which is coming out and goes back up here, and this is this goes to the infusion, the arterial cannula, or the cannula through which you are giving back the blood. This is a VV ECMO patient, and this is the general design of the circuit, and this is how it is handled. So one cannula which is coming out from the drainage cannula, there's a drainage circuit, gets to the pump, from the pump goes to the oxygenator, from the oxygenator goes back to the patient. Again, same thing here. Again, this is the machine where you can set, this is the knob with the help of which you can set the RPM and the ECMO flow, which is basically a part of the cardiac output that you are trying to maintain with the ECMO. And it should be at least 2/3 of your cardiac output, because otherwise the oxygenation is not maintained, or the ECMO doesn't contribute significantly to the oxygenation of the blood. The machine behind here you can see is the ACT machine, which is usually used to measure the ACT. And again, the same thing. This is the cannula which is coming in. This is the pump. This is the oxygenator, and this is behind the blender. And with this cannula is going back. So now, if you need to do dialysis on these patients, you don't need to place separate cannulas, but between the pump and the oxygenator, you can attach the CRRT. There are two ports. One is the arterial port and the venous port. Again, you can just attach the CRRT machine here. The the nephrology technicians are very well versed with this, and they can just attach it to the ECMO machine. Now, it is not only important to know how to start the ECMO, but it's also important to, just like a pilot, you should not just learn how to fly, but also to land. So ECMO weaning is also very important. I've just talked about the VV ECMO weaning here. V ECMO is a much more complex thing, more physician guided, echo guided, so I have not talked about here. In VV ECMO weaning, consider cycling off, that is removing the sweep gas, because if you stop the sweep gas, that means the patient is effectively free of the ECMO circuit. If the chest X-ray is better, but not necessarily normal, the compliance is good. Oxygen sats 100%, stable on 40 to 50% FiO2 on the ventilator. The Plato pressures are less than 30. The PEEP is ideally less than 10. We can decannulate once the patient is with off sweep gas for 6 to 24 hours. Transport on ECMO is a different chapter altogether. I don't want to go into it, but for short transports within the hospital, we need to check, or the nurse needs to check the oxygen cylinders, whether the oxygen supply is okay before disembarking from the ICU, whether the cannulas are secured or not. Patient should not be hypothermic, and the whole team should move as a unit slowly. Somebody shouldn't rush, because if one person tries to pull the bed quickly, another person who is at the foot end holding the ECMO machine and the circuits, that person lags behind, and there is a high chance of cannula dislodgement. This is the picture of Esperanza, which is the girl I showed while starting my presentation, who was the first neonatal ECMO survivor. And this is her picture when she was 21 years old. So that's the kind of hope ECMO can bring to some patients. But we should not be, we should always be realistic. And most of the ECMO survival, particularly in VV ECMO, particularly in severe ARDS, has shown that around 60% to 63% or 65% patients on ECMO survive, but still there is a significant mortality of more than 40%. So that's the truth, that's the reality. But then with that hope, I think we have come to the end of the session. It's almost an hour. If there are any questions, I can take the questions from the moderator or any one of you. And then, so that will be all for today. Thank you.
Thank you, Dr. Chandrashish, for such a nice lecture. It was, this lecture was very well prepared, and I'm very happy to see that you have touched the very basic common things which we miss sometime in ICU. So thank you very much for this nice talk.
Thank you.
Dr. Asif is here as moderator. I request Dr. Asif to, if you want to say something.
Two persons has raised their hands. I don't know how to take their questions, but if somebody can help me, I can answer their questions if they have anything to ask.
Sir, if the questions are to be put, it is put in the chat box. So
okay.
You have. So there is one question from Kavya, sir.
Yeah. Can you please repeat the contraindications of ECMO? Sure. So there are certain contraindications which are absolute, and there are certain contraindications which are relative. The absolute contraindication is that if you cannot give anticoagulation for some reason, because you know, ECMO circuit is something which needs anticoagulation. So that will be an absolute contraindication. And there are some relative contraindications also. For example, the patient does not have much of fruitful life, or obvious, like a terminal cancer patients or severe brain injury, etc. So that will be a relative contraindication of not doing ECMO. Or the patient has been receiving a very high oxygen for more than 80% for more than 7 days, or has been managed with non-lung protective ventilation. For example, a Plato pressure of more than 30 for more than 7 days. Or the patient is very septic and very hemodynamically unstable, and you want to put that patient on PV ECMO, which will make the patient, again, very difficult to maintain. So these are some relative contraindications. But the absolute contraindication is that if the patient is not a candidate for anticoagulation. Any other questions?
Yeah, I'm audible, Chandrashish.
Yes, Asif, tell me.
Actually, the few sister has requested some question. One
Sure.
of the questions is when they face difficulty in maintaining saturation of the patient, if the patient become hypoxic in the ECMO, what they do first? Because we know there are sometimes doctors not in the site, and in especially in the COVID. So initially, to manage till the doctors, 1, 2, 3 things they will do.
Right.
With
Again,
ECMO and one.
sorry,
The question. Yeah.
Your voice is breaking,
The
but I think the
question
question is that what to do if there is hypoxia on while the patient is on ECMO, right?
Yes.
Yes. Okay. So first, let me talk about VV ECMO, right?
Yeah.
So if the patient is on VV ECMO, that means the patient is on ECMO for ARDS, not for cardiac causes. The patient can become hypoxic for certain reasons. It will be difficult for. So what can you do in that situation if the patient suddenly become hypoxic? That is the question. The easiest thing to do is probably to increase the ECMO oxygen concentration, because sometimes people try to increase the ventilator oxygen concentration, which most of the time is not useful because the patients are receiving very low tidal volumes. For example, we try to, at least in our hospital, we try to keep a pressure control ventilation and give a delta pressure control of say 15. Now with 15, and when the patient has been just placed on ECMO, the tidal volume that is generated is hardly say 100 ml, 69 ml, 70 ml, something like that. So even if you increase the oxygen on the ventilator to 100%, it is not going to change. What you can do is you can increase the oxygen on the ECMO to 100%. If the perfusionist is present there, you can try and ask the perfusionist to see if it is possible to increase the flow. There can be a situation where the cardiac output is much higher than the ECMO flow. As I mentioned, if your ECMO flow is not at least 2/3 of the cardiac output, then the contribution of the oxygenation from the ECMO will not be significant. So in that case, if you can increase the ECMO flow, it will match the cardiac output of the patient better and your oxygenation will improve. If you have a problem with the oxygen supply, for example, you have an oxygen failure, that is something which also should be looked at, like whether the the connection, the connection of the ECMO from the oxygen, is there a failure over there? Unlikely, but can happen. I'm not saying it cannot happen. Also unlikely that the ECMO has completely stopped, which is a pump failure. And as I mentioned, if something like that happens, all ECMO nurses, technicians, perfusionists, physicians should know how to do a hand crank. Sometimes if there's a power goes away, the pump completely stops, where you need to do a hand crank, call the perfusionist, and again restart it. So those things are there. In VA ECMO, hypoxia is much more complex. So again, except for increasing the oxygen on ECMO, I think you'll have to call the consultant or somebody, because there can be various reasons for which there can be hypoxia. For example, cardiac failure, competition of the heart with the pump, etc. As I mentioned once in my talk about Harlequin syndrome, the physiology is much more complex. I think that is something I will say to my nurses. Anything if you want to add, Asif, if you have anything in your mind. Hello?
Dr. Chandrashish, there are a few questions in chat box also, if you can address them.
Yes, yes. So the next question I see is, a sedative must be needed for ECMO patient. The answer is, most of the time, as I mentioned, we try to give an analgesic sedation that is mostly analgesia based. As I mentioned, that ECMO circuits consume a lot of fentanyl, so some people prefer to use morphine. You might need sedatives from time to time, but I usually try to avoid continuous infusion of sedatives, particularly benzodiazepines or propofol, because that causes significant delirium and accumulation of toxic products, which can lead to ICU-acquired weakness. Mostly patients having bleeding and with high inotrope skin issues. So how can we control on that? This is the question which has been asked by Hemang Gisavan. So the question is, most patients having bleeding and with high inotropes have skin issues, right? I completely agree that if your patient is on high vasopressors, there will be poor perfusion, especially of the pressure regions, and it will cause pressure sores. So except for the fact that you can change positions, try to decrease the vasopressor requirement as early as possible, try to use certain silicone gel pads to particular areas. These are the things that I will suggest. Obviously, you know better about decubitus ulcer care than me, because you are the ones who do the hands-on care. Bleeding is not really associated with skin issues, but yes, if the bleeding accumulates in an area, and if a particular point is bleeding and that area gets, kind of infected, then yes, that can happen. Another question, Sheikh Nasir has asked, when the patient is already intubated, even though during ECMO, patient get destination, what as a nurse I should do? I think it should be desaturation. I think probably it should be desaturation. So that I already answered. Another question from Shampa Talukdar is, how long ECMO can be continued? So again, VV ECMO can be continued for quite a long time. For example, if somebody is waiting for a lung transplant, it can continue for up to 6 weeks or 8 weeks until the lung is available. It can be continued for a very long time. If the patient is not a candidate for transplants, then usually we start weaning attempts beyond 10 days. That's an average that patients require an ECMO. Beyond 15 days or beyond 20 days, that's beyond 3 weeks, it's prolonged ECMO. But in this COVID, we have seen a lot of prolonged ECMOs. I don't know why. Is it because of the disease itself or because of the steroid use that has happened with COVID? I don't know. But people have, we have seen a lot of prolonged ECMOs. People have been on ECMO for more than 3 to 4 weeks, and survived. But in general, ECMOs are usually around 2 weeks to 3 weeks long. That's in general. And as I mentioned, if the patient requires a lung transplant, etc., that can be very prolonged. VA ECMOs, on the other hand, is usually short because the heart, if you are not waiting for the heart transplant, then the heart should recover quickly. It usually doesn't take a very long time for the heart to recover. It should recover quickly, and then the patients come off ECMO. If, however, the heart is never going to recover and the patient is waiting for a heart transplant, then sometimes that it depends upon the availability of the heart again. I don't find any other questions in the chat box. I don't know if I'm missing something. Asif, are there any other questions?
No, there is no question. And only one important thing, Chandras, is for taking care of the patient, like routine care in a VV ECMO or VA ECMO, because the issue is the mobility of the patient. So giving back care or giving bath to this patient, chlorhexidine bath. So you just mentioned few things, taking care and how they they will do for the especially for the sister.
Yeah, I already mentioned that in my talk, but just to reiterate that. So back care or decubitus ulcer prevention, both of that needs turning of the patient, for which most of the nurses are scared because you have large cannulas and you're afraid that the cannulas can get dislodged. So it should be a multidisciplinary team which should work for this mobilization. What do I mean by that? That means there should be more than one nursing staff or healthcare assistant who is trying to help the patient turn, and there should be a perfusionist who is trying to make sure that the lines are secured and those lines are not getting dislodged. If the cannulas are placed on one particular side, for example, there is what we usually do in our hospital is we do a right IJ and we do a right femoral. So when you turn, if you turn the patient to the right side, then it's the chance that the cannula will get dislodged is much, much less. The most difficult situation is a bifemoral ECMO, when you have the right femoral artery or femoral vein and the left femoral artery or femoral vein both involved. In that situation, turning is really tricky because in either side there will be a problem of dislodgement. But bifemoral ECMOs are for some reason not very common and not very preferred, at least not in this institute. I don't know about other institutes, but it's definitely a little more challenging. What else? And I also mentioned that you need to take care of the ECMO cannula sites, the dressing changes. Usually we use non-occlusive dressings because there is some amount of ooze here and there. So occlusive dressings, just because of sweating or because of blood, the occlusive dressings don't stay. So if you're using non-occlusive dressings, those needs to be checked, and those needs to be changed every alternate day, so that to make sure there's no infection, there is no soiling of that. Those.
One more question, probably this will be the last question. Asked by the Sompa Talukdar, what will be the ACT range and what is the initial dosing of heparin, and what ACT range they will maintain during the ECMO?
So previously a much higher ACTs were required, but now most of the ECMO cannulas that we are getting are heparin coated. So an ACT of 170 or 180 up to 200 is good enough. Sometimes if there are bleeding issues, we come down on the ACT even up to 140, 150 or 160 also. Sometimes if there is a bleed in the brain, we can completely stop the heparin for a few days. And even then we have seen that the ACT with the heparinized circuits and the heparinized cannula gets maintained at around 140 and the cannulas don't clot and it runs. So now it has become very variable, but on an average, if your ACT is around 170, 180, you are good enough. I think that's good enough. And heparin infusion, that's a protocol. It's written in a protocol. So whatever is you're trying to maintain ACT, every hospital has a protocol that what will be your heparin infusion rate, and you just modify and change it according to that.